All right. In this presentation, I want to focus specifically on the topic of osteoporosis. In the last video or videos, I've been talking a little bit about bone remodeling, bone growth, and so on. Now let's take a look at what happens when that bone remodeling process goes wrong, and essentially creates definitely the most common aging metabolic bone disease, otherwise known as osteoporosis. Okay. Definitely one objective that I want to throw at you guys is the new terminology that you're going to get out of this. If you're an A&P student who is new to the subject, you're going to get some new terms tossed at you that relate to not only this disease but other diseases as well that you need to understand. All right, but first, let's just break down the term osteoporosis. Okay, osteo is Greek for bone. Okay, and then porosis. All right, that essentially means porous. All right, porous. So pores in the bone. That's literally what the word osteoporosis means. Okay, and essentially when we say pores in the bone, what happens is the bone breaks down to the point where it looks like there are pores within it, and the bone that's primarily affected by osteoporosis is the spongy bone. Okay, and by now, and I'm going to say right now, if you're watching this video and you haven't, whether you watch my videos or you're learning about this from some other source, you need to understand the difference between compact and spongy bone. Okay, so make sure that you've been through all of that before you go any farther into this topic, because I hate to say it, but you'll be a little lost. Okay, and remember with spongy bone have those trabeculae, those little beams that are within there, and then which are interconnected, and then there are spaces in between the beams which are filled with red bone marrow. And essentially what happens are these beams break down even more. I'll talk about how and why later on, but as these beams break down, these little spaces in between the trabeculae wind up becoming large pores, hence the term osteoporosis. All right. So that's osteoporosis, and which is different than other bone diseases such as osteomalacia and osteopenia, because these two, basically the term osteopenia, osteo is bone. Oops. Okay, and think of the word penia as thinning. Okay, and then there's another term, osteomalacia, okay, which means bones softening. Okay, basically these two terms have to do with the breakdown of bone tissue, but essentially more with the organic collagen aspect of bone. Okay, whereas osteoporosis is a disease that's very different than these two. Okay, so keep that in mind. Osteopenia means the thinning of bone, which is going to happen as we age. I mean, our bone density is going to get more thin as we age. All right, osteomalacia you tend to see more with diseases, for example, hyperparathyroidism, and when your parathyroid glands are overactive and squirt out too much PTH, that will cause excessive breakdown of the organic aspect of bone and make them soft and more breakable. Or that's often what's called brittle bone disease. All right. So osteopenia, this is a term we're going to come back to, because like I said, as we age, as we get older, our bone density goes down, and our bones are going to thin out anyway. Okay, but some people go a step farther and get tossed into the disease osteoporosis, and we'll talk about how and why. All right. So your bone disease terms, and now let's talk about the difference between primary versus secondary. All right, and like I said, this is something that's not only going to apply to osteoporosis, but apply to other diseases you're learning about as well. All right, when we say a disease is a primary disease, all right, basically think of it as natural causes. I know that sounds kind of goofy, but and then secondary, think of a disease as more of a complication caused by another disease. Okay, so for example, with osteoporosis, all right, primary osteoporosis is when your physiology changes as we age, or there are other factors that play into it, but let's just go, for example, the most common group of people that are afflicted by osteoporosis are postmenopausal women. Okay, postmenopausal women. Okay, and eventually estrogen levels are going to drop as a result of menopause in females, and which is just a normal part of aging, but unfortunately it has its ramifications. And as a result, as the estrogen levels go down, that's going to make the bone, that's going to create a thinning in the bone, the bone density to become smaller. And then as a result, and then if this isn't taken care of or treated properly, then a person is going to develop osteoporosis. Okay, so that's just something natural that's going to happen. And estrogen, basically one of the androgen sex hormones, okay, is probably one of the more common hormones that revolves around this condition. All right, so that's primary osteoporosis. Secondary osteoporosis. Osteoporosis would be a complication brought on because of another disease. So the primary problem of this individual would be another disease, but that other disease may cause osteoporosis. For example, parathyroid hormone. Okay, if people oversecrete that, then that could cause, the excessive breakdown of bone, from osteomalacia to osteoporosis. Or if there are certain blood disorders, certain leukemias, and so on. So the person has another disease, and osteoporosis is a complication as a result of that disease. All right, or a malabsorption disorder with the GI tract. You get the picture, okay? And another very common example of the usage of primary and secondary is going to be with hypertension, otherwise known as high blood pressure. Okay, and then there's primary and there's secondary hypertension. All right, primary hypertension is what we would call idiopathic. Idio is Greek for idiot, pathic of as disease. So basically we're idiots because we don't know the cause of the disease. All right, so basically it's idiopathic. So what we're saying here is that some people just get high blood pressure. No, not some, a lot. Okay, and again, usually happens as we age. And if there isn't anything else exacerbating the hypertension, then or exacerbating their physiology, like chronic stress and other disease or so on, but their blood pressure just is naturally rising, we would call that primary hypertension. But if the person has, for example, let's say, diabetes, mellitus. That's the blood sugar abnormality that revolves around the hormone insulin. Okay, but in the end, both, whether you're talking type 1 or type 2, both cause hyperglycemia. Okay, elevated sugar levels in the blood, and that's going to elevate your blood pressure. Okay, so the primary problem here is obviously the diabetes, but high blood pressure, amongst other complications, would be secondary to this. Okay, so keep that in mind, primary versus secondary. All right, and then risk factors. Risk factors. What risk factors are, let me erase some of this mess here before we continue. Let's just go like this. That's so cool. All right. So with risk factors, essentially what risk factors are let's kind of define these. Basically, these are, we'll say they're items that increase your chances of getting a disease. So risk factors increase your chances of getting a disease. Okay. And there's two types of risk factors out there. There's what's called modifiable and then non-modifiable. Okay. Modifiable risk factors are risk factors that we have control over. Non-modifiable, we have no control over these. Okay, so let me ask you guys this. What are some aspects of your life, of your physiology, whatever you want to call it, that you have absolutely no control over, that the bad things are just going to happen, or could potentially happen just as a result. Okay, what do you guys think you have no control over in your life? That there's nothing you can do to change these aspects of your life? Well, age. We're going to age. And as we age, things break down. Parts get worn out, and we have a harder time fixing and replacing and handling these parts that are breaking down, and as a result, that causes complications. Gender. There's nothing you can do about that. Okay, physiologically, you are who your gender is your gender. Okay, and certain genders are more susceptible to certain diseases. For example, we're talking about one right now. Osteoporosis is much more prevalent in women than men. Okay, much more prevalent. And I mentioned why earlier, because of menopause. All right, race. There are certain races. Physiology varies within certain races. Okay, race is a factor in medicine. Okay, and and there are certain races that even this disease we're talking about here are going to be affected by, but they're going to be more affected by it than others. For example, this is a disease that affects primarily Caucasians and Asians. Okay, whereas the black populations you don't see osteoporosis very often in them. Okay, and I'll talk about why in a little bit. Just genetics. You can't control the genes you inherit. And there are plenty of diseases that move from generation to generation to generation. All right, but does that exactly mean that you're going to get a disease if the gene is in your family? In some cases, yes. There are some diseases out there that we just have no control over. Huntington's chorea is a good example of that. But just because lung cancer is in the family, does that mean you're automatically going to get lung cancer? No, but are the chances there? Absolutely. And this is where the modifiable risk factors come in. All right, modifiable risk factors are more or less lifestyle type risk factors, how you choose to live your life, what you can actually control. And some very common examples of modifiable risk factors would be activity levels. Are you an active or a sedentary individual? More sedentary individuals are going to be more prone to osteoporosis. More active people are going to either not get osteoporosis, or it'll happen later and it will not be as severe. All right. Nutrition. Do you choose to eat nothing but Doritos and Little Debbie's? Not enough protein. Do you choose to be a vegetarian or a vegan, or do you choose to, just do something nutritionally, or do you choose to eat a lot of protein, or eat a well-balanced diet? It's up to you. All right, but what you eat will affect your chances of not only getting this disease but others as well. Drugs. I'm talking about the recreational kind. Smoking, excessive alcohol intake. If you decide to go a step up and take the more heavy narcotic type drugs, okay, that's something you have control over. All right, so basically you get the picture here. So basically these factors we have control over, and now, I'm not sitting here telling you that if you're an active person, if you eat right, if you don't do drugs, that you're not going to get any diseases, or you're not going to get diseases that are within your family. Like I say, as I mentioned before, these increase, you got to pay attention to this term here. The chances, okay? If you live a good, healthy lifestyle, you'll decrease the chances of acquiring a particular disease. That doesn't mean you're not going to get it. Okay, you have to keep that in mind. There are plenty of people out there that are extremely active that still have clogged arteries. A guy that I used to run cross country with not too long ago, he's a few years older than me, but not even 40, and had a stroke. And this guy was this guy was all national. You know, so I mean, and still ran a lot to this day. Can't really anymore, but you get the picture. That's just, you know, there are just instances where genetics just doesn't care. Okay, so you have to keep that in mind. So those are risk factors. All right. So again, make yourself privy to this new terminology, not just for the purpose of this topic, but for other topics as well. Because when it comes to understanding diseases, I mean, especially primary, secondary etiology, and understanding what risk factors are. Okay, though that's extremely important in terms of understanding not just how diseases manifest, but also you guys are going into the healthcare profession, how you can do what you can to prevent diseases or manage diseases and treat them. All right. All right, so now let's get into the pathogenesis of osteoporosis. Basically what osteoporosis is an imbalance of the remodeling process. And remember, we've mentioned before that bones are not only the most organized, they're the most dynamic form of connective tissue within the body. Okay, bones are constantly adding and shredding layers off of themselves. Okay, but we normally have a balance between these activities. The reason why we need to take down layers is because, remember, bones are made out of more than just calcium. They're made of cells and fibers, collagen fibers, and like anything living and organic, they die and break down. So when those organic parts of bone start to break down and fall apart, we have to digest and eliminate what's left before we can create and add new organic parts to that space. All right. So there's usually a good balance between these two activities, and we can hormonally regulate these activities, and we can regulate these activities through how active we are as well. Because remember, the number one largest factor in maintaining your or not maintaining your bone mass, but just in terms of maintaining a good healthy bone mass is mechanical force. How much mechanical force do you put on your bones? Basically, how active are you? How much are you making muscles contract and pull on your bones? All right. So what we're saying here is that there's an imbalance in this process of taking away layers and adding layers. And obviously, when we're talking about an imbalance, the imbalance favors the stripping of the layers of bone, which remember is called resorption. Resorption. And remember, the adding layers is called deposition. So there's an imbalance between deposition and resorption, and again, that imbalance favors the resorption process. And remember, just for a little review, what are the cells that drive these two processes? I'm not going to tell you those right now, but again, you should be thinking about this. Okay, so what can cause an imbalance in this remodeling process? Okay, and there are three very common factors that fall into here. One of them is a failure to achieve a peak bone mass. All right, a peak bone mass. So what we're saying here is, at some point in time in your life, your bones are going to reach a peak, or I don't want to say a maximum, but a peak density. Okay. And usually that happens, between the second and third decade of life. So in your mid-20s to your early 30s, our bones are going to get about as dense as they're going to get naturally on their own. Then it's up to us to maintain that density through an active lifestyle. All right, but there are plenty of people out there that don't get to this point, that don't reach their peak bone mass for whatever reasons, because maybe they've got a hormonal imbalance or another disease. They've got a malabsorption problem with their GI tract. Their nutrition is poor. They're not very physically active. Okay, I mean, they didn't get enough sunlight, not enough vitamin D in their system. All right, so whatever the reason may be, if they don't achieve a peak bone mass, then as a result, their bones are going to be a lot easier to break down, which will make them, just be easier to fall into osteoporosis. Okay, bone loss caused by increased resorption. This is probably this point we're going to probably focus on the most. Okay, this is where the postmenopausal women come in. All right, because estrogen, Okay, estrogen basically lowers the amount of resorption taking place. But if your estrogen levels start to plummet because of menopause, then you lose a very important hormone, a very important chemical signal that essentially allows your bones to deposit minerals, minerals and collagen and within the matrix of the tissue itself. All right, or inadequate deposition. Okay, again, it could be caused by hormonal issues. It could be caused by poor nutrition. Because remember, it's not just calcium that's important. You have to have enough protein in your diet. All right. I mean, what do you think collagen is? Collagen is a protein. When I say fiber, remember, by now you guys should be acquainted with that. Whenever I say fiber, you should think protein. Okay, and if you have an inadequate protein intake, then your bones are going to become weak. And, you could see this if a person, decides to become a vegetarian or a vegan or all the above. Well, I guess they're two different things, but they're both goofy. And anyway, if voluntarily, there's some people who are vegetarians because they're allergic to meats and so on, but for example, if you're a vegetarian and you're not good at it, I mean, people who have been vegetarians for a long time and are healthy are people who have really done their homework and who are very good at doing it. Okay, and kudos to them. I just personally don't want to put that much effort into what I eat. But a lot of times people try becoming vegetarians for whatever reasons, to lose weight, because they think it's healthier to quote unquote detoxify their body. I hate that term, detoxify, to do whatever. But then in the end, after about a month or two, they realize this isn't for them because they're weak. They get sick all the time. They have no energy because they're not taking enough protein, and then as a result, they say, okay, forget this and go back on the meat wagon. All right. So these are the three more common causes of osteoporosis. And a person, you got to remember, could have a combination. It doesn't just have to be one of these points. It's usually one or but it's usually at least one of these. That's what I'm saying. Okay. And remember, pathogenesis, the development of a disease. All right. So what are some risk factors that would throw a person into one of those categories of the pathogenesis we just talked about? One of them is body size. Okay, people of smaller stature, people who are smaller tend to be more prone to osteoporosis. And I mean, this should just make sense because people who are smaller tend just to have, lower bone mass, or I should say lower bone density, thinner bones. All right, and that's where the race aspect of this comes in. That's why this is a disease that predominantly affects Asians and Caucasians. Okay, because Asians and Caucasians tend to have a lower bone density compared to, for example, the black population. Blacks do have a thicker bone density. That's why you rarely see the disease among them. I'm not saying it doesn't happen, but it's not as common. All right, so gender. Again, this disease, I mean, if you want to talk about, out of 10 people, I'd say 8 or 9 out of 10 people that have osteoporosis are going to be female. All right, and again, the big reason why is because of the decline in estrogen as the female ages. All right, whereas men do get osteoporosis. Men will definitely go through osteopenia. There we go. Men are definitely, their bone mass is going to thin because as men age, their muscles are going to get weaker. They'll become less active. Their diets are probably going to start to slip as they get older, and they're going to shrink down and they're going to get smaller in size, and their bone mass is going to thin as a result. But men don't have a severe change in estrogen like women do. Estrogen levels will decline a little in men. Testosterone levels will decline a little in men, which will also play a role in the drop in the bone mass. But they'll still maintain, fairly normal levels of the hormone, and which as a result will allow them to basically not fall into the category of osteoporosis. They'll usually just go about this far into osteopenia. All right. So gender is a very big role. I mean, gender is, definitely a very large role in this. Again, nutritional factors. Okay. I mean, everyone always talks about calcium, which they should, because, without enough calcium, without enough mineralization of the bone, you're not going to reach that peak bone density. And then as a result, you're going to be problematic. Okay. And calcium is very important to not only preventing osteoporosis, but in treating it as well. And this is something, that a lot of people don't talk about as much. But again, I've said it a couple times, protein as well. You have to have an adequate protein intake as well, so you can fuel this process and create the calcium and so on. And hormonal imbalances. All right, that's where the estrogen levels come in. All right, that's where the estrogen comes in. Or if a person has, or if there's other secondary conditions. All right, but definitely estrogen is the most common hormonal imbalance you're going to see that throws people into osteoporosis. Okay, so out of all these risk factors, which ones are modifiable? Out of these risk factors, which ones are modifiable? Actually, I should have thrown another bullet point in here: sedentary lifestyle. Being a sedentary human is a good way to increase your chances of getting osteoporosis as well. So I'm glad I remember to throw that in there. But again, which one of these out of everything I listed here are modifiable? Okay, the nutritional factors and the sedentary lifestyle are definitely factors that are going to increase your chances. And I mean, people say smoking causes everything, but so I'll throw that in there. Okay, but this is something we have control over as well. Okay, so these are items that we can actually control that play a role not only in treatment, but even more importantly, a role in prevention of getting the disease. Now, again, that doesn't mean that you could have the most perfect diet. You could be a fairly active person, not smoke. It doesn't guarantee you're not going to get osteoporosis. It could happen later in life. It just means your chances are going to be a lot lower. Or if you do get it, it just won't be as severe. All right, but body size, I guess body size, I mean, you do have, I guess we would kind of put this 50-50 because, I mean, you don't have control over your height, but you do have control over, how, if you're a very active person and you have a good muscle mass, you're going to have a good bone mass as well. So from an exercise standpoint, I guess we have control over your body size, but in terms of how big or small you are, in terms of height and bone mass and density and all that, there's some aspects of that are just out of our control. Okay, race, obviously, race and gender, there's not a whole lot we can do about that. Same thing with the hormonal imbalances. Okay, so these are the risk factors that allow a person to fall into osteoporosis. Now let's talk about the pathogenesis, or, a little more about the pathogenesis of this. All right. So spongy versus compact bone. So remember that, so let's say we draw, let's say this is a femur, or supposed to be a femur. Hopefully your femurs don't look like this, people. All right, so this would be the neck of the femur. Now remember your parts of a bone. This would be the diaphysis. All right, this would be the epiphysis. All right. And these two structures put together are essentially going to, remember in the diaphysis is the shaft of the bone. The epiphyses are the enlarged ends. All right, and remember within these enlarged ends, they're filled with spongy bone. Okay, and then in the diaphysis, this is where you find the compact bone. Okay. Now, people who are aging, again, both of these types of bones are going to thin. Because remember, when you're looking at spongy bone, okay, when you're looking at from a histological perspective, when you see these little beams, or what are called trabeculae, okay, that's compact bone. Oops. Okay, that's compact bone. But you notice that there's a lot of space and there's pores in between these beams of compact bone. Whereas when you look at, the true compact bone within the shaft of the bone, that's where you remember you find those osteons, those haversion systems. You've got the central canal, you've got the osteocytes that encircle them. Then you got another canal, then you got another osteon, and then some more osteocytes. And then in between all these osteocytes, you've got your bony matrix, which is a combination of collagen and cells and minerals very tightly packed together. Okay, so compact bone is a lot more strong and secure than spongy bone. All right, and remember the cells that are involved in both of these types of bone that make the remodeling process take place: osteoblasts and osteocytes. Okay, osteoblasts and osteocytes. Remember, osteoblasts are responsible for deposition. Did I say osteocytes? I'm sorry, people. Osteoclasts. Osteoclasts. And osteoclasts are responsible for resorption. Resorption. The breakdown of bone. All right. And this is where the menopause aspect of this comes in, because estrogen, and I'll throw a URL on the YouTube video and also on the site Sophia that I'll be putting this on. I'll throw a link to a good website that has some good articles and explanations about this as well. But essentially what estrogen does is estrogen promotes, one, apoptosis of osteoclasts. All right, apoptosis of osteoclasts, and kind of lowers the amount of differentiation of stem cells, or stem cells into osteoclasts. Okay, and it plays a role in by binding to certain receptors and regulating the activity of osteoclasts in a nutshell. All right, so basically what you can say is that estrogen keeps the osteoclast levels down. Okay, estrogen keeps osteoclast levels down. All right, but then when all of a sudden when a woman goes through menopause and her estrogen levels just plummet, they don't go down to nothing. Okay, because the kidneys and the liver are going to work together to produce a little bit of estrogen, but not nearly as much as she was manufacturing earlier in life. All right, and as those estrogen levels severely plummet, now all of a sudden you lose one of your main chemical hormones, chemical messages that basically keeps the osteoclast numbers down. So then as a result, osteoclast levels are going to rise, and then you're going to increase the resorption process. And then you're going to continue to break down and break down and break down and break down bone. Okay? And again, this compact bone is going to thin, osteopenia, but the bone that's greatly affected by this is the spongy bone of the body. Okay? And so what's going to happen are these little beams, these trabeculae, they're going to break down and they're going to thin, and then what's going to happen is, what you notice about the size of the pores? They're a lot larger now. They're a lot larger now. And then when you look at this under the microscope, you can see that these pores are a lot larger. These beams just look really ragged and structurally just they don't look like they have a lot of integrity. Okay? So then what's going to happen is that's going to make these bones weak. All right, and one of the major complications that's going to come with this is the areas of the body that we tend to bear a lot of weight on are going to break. They're going to break a lot more easily. For example, I made a pretty sad attempt here to draw the femur and the neck of the femur, because you always hear about people with osteoporosis breaking their hips. All right, so what's going to happen then is these, as the spongy bone, gets weaker and weaker and more porous within the neck of the femur. You always hear these stories about an elderly person that, they've fallen and they can't get up and they broke their hip. I mean, most of the time, these people don't fall and break their hip. They're falling because their hip is broken. You know, osteoporosis is essentially what we call a silent disease. Okay, what we mean when we say a silent disease, there essentially are no symptoms. Oh. And there really aren't any signs either. So you don't know that you're actually going through the disease itself. Same with primary hypertension. All right. So you can't just feel your bones getting thinner, but then all of a sudden one day you'll be walking up and down the stairs. You know, you take a step up the stairs, and when you plant that foot, you know, so let's say you're going up, and then you know you have to plant that foot down, and you have to lift yourself up and put more weight on your hips. Well, all of a sudden this bone's going to be really weak and crack. It's gonna crack. And then they're going to fall, and then obviously if they fall or they fall downstairs or onto the floor, they're probably going to do more damage and maybe even break their other hip in the process or break other bones. All right, so that's one common area. So basically there are 3 areas that are the most greatly affected by osteoporosis, and these are areas where there's a combination of spongy bone plus areas that are very high weight bearing areas. And obviously that one is the hip. We'll go neck of femur. Oops. Another one would be your vertebrae, especially lumbar. Okay, even though your lumbar vertebrae are the biggest, remember, when you look at the anatomy of a vertebrae, you know, you've got the body, then you've got your lamina, then you've got these transverse, then you've got the spinous process. Remember, the body is all spongy bone. All right, and you don't need me to tell you that this is an area of the body that's taking on a lot of weight. So oftentimes, you know, somebody may get what's called a compression fracture because these bones get so weak, and just as a result of you shifting your body around or doing whatever you're doing, as the compressive forces are applied to the vertebrae, that could crack or fracture a vertebrae. All right. And then the other area would be the wrists. Okay, you know, the distal end of, you know, obviously the distal forearm. You know, obviously, there's not too many people walking around on their hands, but you have to use your hands and your wrists quite a bit throughout the day. All right, so as a result, let's say you go shopping and, you know, you pick up a shopping bag and it's a little heavy, and all of a sudden, boom, your wrist fractures. All right, and then as you can see, you know, that's the most biggest complication that comes with this is fracturing bones. But at the same time, you can also see how this can be rather bad because, you know, if a person breaks their hip and falls, they could hit their head. If a person, you know, breaks their wrist, their ability to live life could be very limited. Okay, if someone fractures their vertebrae, again, they're not going to have a good quality of life. And at the same time, what if there are bone splinters from that damage the spinal cord? Okay, so even though, I mean, there are worse things that can happen to people than breaking bones, as you get older and your bones fracture, that's going to make life not very fun. All right, so the complications of breaking these bones are going to be relatively hard on a person that has osteoporosis if it's not treated properly. Okay. And then, which kind of leads me into this, the treatment aspect of osteoporosis. You know, there's a reason why I started with this bullet point. The best medicine is prevention. Okay, but the best medicine by far is prevention. All right, and essentially with prevention, you know, that comes from, you know, again, a good diet. You know, understanding the modifiable risk factors for the disease. You know, good diet. You know, exercise. You know, I think it's pretty sad. You know, I'm from the, you know, I know there are some people that from other parts of the world that listen to this. You know, I live in the United States, and I think it's pretty sad that we have to encourage people to, you know, just to become physically active. We say you need to, you know, we become so lazy as a society that we try to encourage people to have so much physical activity per day, you know, by walking your dog or taking the flight of stairs instead of the elevator. I mean, we need to push people back into exercise mode. Okay, we need to get back into exercise mode because, I mean, if we've gotten so lazy to where we're trying to encourage people to take a flight of stairs instead of an elevator, or walk around the block, or do something, or you know what I'm saying, just to make a person a little more active, we got problems. And, I hope people don't wonder why there's so many health problems over here. All right. I say, instead of throwing around the word, physical activity, exercise. We need to promote that more, because the exercise is what is going to give a lot more benefit to the bones. Okay, and you don't need 2-3 hours a day to exercise properly. If you're efficient and know what you're doing, then, I mean, and a good solid hour can be a very quality exercise session for somebody. And if you're a person out there who's listening to this and you don't know a lot about exercise, talk to somebody. There are personal trainers, there are health and fitness specialists, there are exercise physiologists, which is what I am. There are plenty of people out there that can give you quality advice on how to exercise properly. So again, let's get off the physical activity bandwagon and get back on the exercise train. Okay, but a combination of good diet and exercise is a good way to prevent, or at least limit, the effects of osteoporosis. And again, that comes from adequate calcium intake, protein intake, and so on. Okay. But like I said, that doesn't mean you won't get the condition. And what a lot of when people do get osteoporosis, they do have to make modifications in their diet. One of them is they typically make a person increase their calcium intake. Okay, a person with osteoporosis can exercise, but you have to be careful. Okay, you have to be careful with the weight-bearing exercises with a person who has osteoporosis, or even doing something as simple as sit-ups. You have to make sure, if you're going to, whether you're going to be a doctor, a physical therapist, whatever it may be, occupational therapist, whatever it may be, and you're working with somebody that has osteoporosis, you have to bear in mind, even with something as simple as sit-ups, you have to pay attention to their mechanics and how they perform the sit-ups. Okay, because their bones are weaker than the average person, and if their technique is off and these weak bones are bearing weight that they can't handle, I mean, you could cause some damage when we're trying to help them. Okay, so exercise can help a person with osteoporosis, but there has to be some changes made. But again, exercise prior to menopause, or prior to menopause, is obviously better. All right, hormone replacement therapy. Okay, that's what HRT stands for, hormone replacement therapy. Okay, or what's often called ERT, estrogen replacement therapy. Okay, which is very effective. Okay, estrogen replacement therapy is quite effective, but there may be some complications that come with this too. And one of the more common ones is breast cancer. Not saying that if a person is going to get estrogen replacement therapy, they're going to get breast cancer. I'm just saying there's a chance, there's a risk there. Okay, and if you're a person listening to this right now who's worried about getting this, or if you're a healthcare, most of you are going to be future healthcare professionals, just bear in mind that you have to educate your patient. Okay, if you are a person who's going through this, do your homework, talk to your doctors, talk to your healthcare professionals, and just weigh the pros and cons. Because I mean, the choice is yours. Okay, if you're a patient, all right, just make sure that it's the right choice. Okay, and there are certain medications out there that basically enhance, that range from enhancing, our ability to absorb calcium more efficiently, to dealing with the remodeling process of bones. A very popular class of meds out there called bisphosphonates. Okay, and you guys can research those a lot more. Parathyroid hormone replacement there, given to people as a medication, and so on. Calcitonin, I believe, has been experimented with. So, but bisphosphonates are probably one of the more common types of meds out there that are going to be given to people to help deal with osteoporosis. That, and like I said, calcitonin is another good one. Because remember our talk from hormonal regulation of bone remodeling. Calcitonin essentially promotes the deposition process and slows down the resorption process. So, All right. And then on this last slide, I'm not going to go terribly in depth with this, but again, there are just, when it comes to secondary osteoporosis, there are various, again, these are some various complications that could cause a person, for example, Cushing's. If a patient has Cushing's, that can cause osteoporosis. If a person is immobilized for whatever reasons. GI disorders, if you're not absorbing calcium, that's going to be a problematic. Connective tissue disorders like Marfan's and others. Okay, you have to remember bone is a connective tissue. And, and so there are certain connective tissue disorders that could cause a person to have this. Hematopoietic disorders, blood cell production problems. Okay, and the last one is called the female athlete triad. This is essentially when women work out really hard and then their body fat levels get really low. They don't menstruate. Typically they have an eating disorder, and then as a result, their estrogen levels tank, and then they develop osteoporosis, hence the triad. Okay, the menopause, the eating disorder, and then the osteoporosis, all at the same time. All right, so again, these are some secondary causes of osteoporosis, and I'll let you guys research these a little more on your own. But, again, I hope this video was informative for you folks. But, again, this is a good way to take what we've been talking about in terms of the remodeling process of bones and actually clinically apply it to, again, a very common bone disease out there. Like I said, this is the most common metabolic bone disease out there. So basically, and remember, by definition, osteoporosis is a disease in which the remodeling process is disrupted, where resorption outdoes deposition. Okay. Take care, and as they say in the Red Green Show, keep your stick on the ice, folks.